Fine. Hi, Doctor. We can start the
Okay.
CME.
All right, sure. Hi, good evening. I'm Dr. Mahesh Sitampalam, and I'll be moderating this session today. Before I start, let me wish all of you a Happy New Year, and thank you for participating in our very first webinar. This is our first webinar for this year, and it is co-hosted by both MSART and EP+. We also take this opportunity to thank EP+ for their continuing support for our CME. Now, before we start with the speakers, I just want to introduce you or bring you up to speed to some of MSART's plans for 2024. So I told you, this is our first webinar. We aim to foster greater engagement within our IVF community so that together we can enhance and advocate for better IVF services across Malaysia. We plan to have this monthly webinars. Actually, we have planned 13 webinars for this year. Our next webinar will be on the 31st of January, which is Wednesday at the same time. And we hope inviting experts from various IVF domains to share their experience. But more so, we want participation from you, the participants, so that you can give us your viewpoint. We can have diverse perspectives on the topic, and hopefully we can have more open discussion. We also hope that these sessions will serve as informal gatherings where we can improve our teamwork as we face the challenges ahead in the IVF services in Malaysia. MSART takes this opportunity to thank all of you for your active participation in our in-person 2023 conference, which was an overwhelming success, which was a pleasant surprise. And building on that success, we plan to host another in-person conference. Hopefully, this can be an annual affair. And our conference will be on the 5th and 6th of October, 2024. So please block these dates, 5th and 6th of October. And we hope this will be able to improve our knowledge, our networking, and friendship. Finally, before I invite the speakers, I would like to invite all of you to join MSART. Take as members, those who have not already joined, take advantage of our preferred rates for registration for the conference. And also, please do not forget to attend our next general meeting on the 25th of February, which is a Sunday. And we'll be sending out the circular soon. This is the election year. So attend, make your voice heard, and make your vote count. All right? So with this, I would like to introduce our topics and speakers today. Our first speaker is Mr. Daniel Morgan. He comes with a very impressive CV. Briefly, if I can say, Dr. Morgan will enlighten us on a radical approach to stress reduction in culture and riding the antioxidant wave. Dr. Morgan completed his PhD in 2008 in epigenetics at the University of Queensland. He began his journey in assisted reproduction in 2010 at Sydney, Australia. Dr. Daniel Morgan has been deeply involved in embryology training during the past 12 years and has been the primary trainee of new embryologists for the past 8 years. He has worked in Thailand, China, and Dr. Daniel is currently the scientific director of Monash IVF, Queensland, since March 2022. He has recently overseen the transition from sequential media to single-step media containing antioxidants for Queensland's 2 largest clinics. This is a first for the Monash IVF group. So, ladies and gentlemen, this is a topic on stress reduction. So don't get stressed, buckle up, and get ready to ride the antioxidant wave for even greater success in IVF labs. So, Dr. Morgan, over to you.
Thank you very much for that kind introduction. Just let me share my screen. Okay, can you see that screen?
Yes, we can see the screen.
Great. Yeah, so thank you for that very, very kind introduction. And firstly, I'd like to thank you to the organisers of MSART for giving me the opportunity to I guess, chat very briefly about our experience with the GX Media Suite so far. I'm based on the Gold Coast in Queensland, Australia, and I look after all of Monash IVF's laboratories in Queensland. I guess the experience I'm presenting this evening has come from our 2 largest clinics in Queensland, which are Brisbane and the Gold Coast, which are about an hour's drive apart from each other. Before I go any further, I do need to give credit to Kate Watson, our regional laboratories manager, who came up with this very clever play on words to tie this talk in with what the Gold Coast is best known for, which is our beaches and our surfing, hence waves. Truth be told, she suggested I give this talk in a wetsuit, but even though this is the Gold Coast, I thought that might be going a little bit too far, and besides, it's late in the evening now, so it's way too late for a surf anyway. So I guess just briefly touching on what I'm going to talk about this evening is, culture is stressful for embryos, but it is also stressful for embryologists as well, and we need to be mindful of that as managers as well. So how do we look at reducing stress for embryos and embryologists at the same time? And believe it or not, we can do both at the same time. Why did we make the change to single-step media from sequential media? How did we do that transition? And it's really important for us to bring everyone along for the ride, and change management is a critically important piece, an important part of the success of this change. So we needed to have both staff and clinician or doctor engagement, and we need to be really clear with our implementation and transition planning as well. So I'll just talk you briefly through, I guess, how we did that in about 20 minutes. And I'll talk you through our preliminary results comparing our sequential media to our single-step media, and then further our single-step media with antioxidants. So, like I said, embryo culture is stressful. For the embryos, there are multiple sources of oxidative stress. So free radical oxygen species, or ROS, such as hydrogen peroxide, superoxide, and hydroxyl. We know that these are unstable, they're highly reactive, and they can come from oxygen itself, light sources within the laboratory, the culture media, and the environment, the embryo metabolism. And we know that these will all negatively impact embryo development and outcomes. And that's been fairly well established for quite some time. But also looking at the embryologist side of things, especially when we're in sequential media and I guess individual culture, there's a lot of manual handling of embryos. And so, that itself increases stress and risk into the culture system. Sometimes we've got very demanding clinicians. We've probably already experienced that. Managers, scientific directors as well. Not this one. I would never do that. But one thing that we also need to be very mindful of is managing our high patient expectations. Increasingly in the world of Dr. Google and social media, we are all aware that patients are becoming increasingly informed, notwithstanding that the quality of that information can sometimes be very dubious at times. But so they come to us with greater expectations than ever before, and we need to be ready to answer their questions as well. And sometimes that is stressful. As anyone presenting at MSART or any kind of webinar or conference will tell you, generally it's not the presentations themselves that bring the presenters stress, it's the potential questions that follow. But there's certainly of stress for embryos and embryologists, but that's probably a talk for another day. So how do we reduce the stress? again, we'll look at the side of the embryos, we can minimize, we need to aim to minimize their exposure to oxygen and therefore the sources of oxidative stress. We can culture them in a low oxygen culture environment, and that's fairly routine these days across the globe. What is less routine, but very, very effective, is creating an uninterrupted culture system utilizing the combination of time-lapse technology and single-step media. And that has the added benefit of reducing the embryologist stress as well, because we're reducing the amount of manual handling required by embryologists. Antioxidants in a culture media is increasingly, gaining a lot of traction, and there's certainly a lot of chatter about that, and I'll certainly talk a little bit about that today. Use of IVF chambers to reduce the need for embryologists to work at speeds that increase risks associated with manual handling in high oxygen environments. And so, having a controlled environment that is controlled both in terms of temperature, but also CO2 concentration. That's for the use of for the embryologists, and helping to reduce their stress. Electronic witnessing can help to reduce distractions in the laboratory. We know that obviously double witnessing is a critically important part of everything that we do from a quality and risk perspective. But it does introduce a lot of distractions within the laboratory. So, introducing electronic witnessing wherever we can to reduce those distractions can help to reduce risk and stress for the embryologists as well. We could fall asleep and dream of a world in which demanding clinicians and managers and scientific directors, demanding patients, don't exist. But the reality is that reality kicks in, and so perhaps we look at innovating the ways in which embryologists work. So one thing we could look at is a hybrid working from home model, and that certainly requires IT infrastructure, which needs to work really well. But I have seen this work really well at clinics that I've worked at in the past. We could go for a Google style sleeping pod so that we can go back to sleep dreaming of a stress-free world. But I think that's probably not very realistic, but I digress. So why did we make the change to single-step media, specifically GTL, and then later GXTL? Certainly the formulations of single-step media have improved significantly over the last kind of 5 or 10 years. And I guess we've got increased confidence in maintaining that culture environment. So maintaining a stable, undisturbed culture environment, which we know is certainly beneficial for both embryos and embryologists as well. So we've got less interruption to the culture, less handling, so there's less risk, less stress. There's less variables in the system, so we've got reduced risk and increased traceability. One of the biggest challenges of running a high quality IVF clinic or high quality IVF laboratory is how well do we control the variables within that laboratory? And we know that there are lots of variables, anywhere between 200 to 400 variables on any given day. And controlling those variables as best as we possibly can helps to improve the overall quality of our culture system. And for us, it was the next logical step in continuous improvement for our patients, was to make that transition from sequential media to single-step media. Although historically at Monash IVF, we had primarily used sequential media suites, we had some brief exposure to single-step media in our Gold Coast clinic, demonstrated quite nicely by this paper, where in this case study published a few years ago, of a patient whose eggs were all zona-free. So we used GTL in order to minimize the manual handling of her embryos, and ultimately that resulted in a live birth. So based on these factors, and also my experience and observations throughout my travels across the globe, both in Australia and Southeast Asia, culture systems using single-step media containing antioxidants generally perform very well. So it wasn't a hard decision for us to make the move from sequential media to single-step media. There's lots of information out there about the antioxidants contained within the GX media suite. So rather than replicate that information, I thought I'd kind of form more focus on how we manage the transition in our highest volume laboratories in Queensland. So that's Brisbane and the Gold Coast. As an aside, during my interview process for this current role, our biggest doctor on the Gold Coast, and when I say big, I mean volume cycle, not physical size, Dr. Keong asked when we could implement single-step media on the Gold Coast. So I took that as a positive sign that there wouldn't be too many hurdles to implementing this change from a stakeholder perspective, and it's really important that we take that into account. We need to bring everyone in the clinic along for the ride and have them invested in the change. So that is, the clinicians, especially the embryology staff, the nurses as well, and providing education sessions for all of those stakeholders and the patients as well. As managers, we can have great plans in place, but ultimately it's the execution of those plans in the laboratory that ultimately determines impact of the changes. So it's for this reason that staff engagement is actually critically important for the successful change management, whatever change you're trying to implement in the laboratory. And I am incredibly grateful for the scientific teams that we have here in Queensland for Monash IVF who implemented these changes incredibly well, and certainly early stages show that the results are looking quite good, but I'll get to that in a second. So we developed an implementation plan, which included things like developing the laboratory work instructions, so the timing of refresh, which we actually don't do anymore, but the timing of assisted hatching. And this also included changes to the laboratory paperwork to reflect these process changes. We had multiple scientific team education sessions where they had the opportunity to ask questions and truly understand the benefits of the changes and I guess the practical implications for their day-to-day work. Doctor and staff engagement and education, really important. We developed just some very simple, frequently asked questions for patients. And again, that was, quite often our nurses will have that initial interface with the patients about these kinds of things. So it's important for us to provide the nurses with some tools where they can answer these questions for patients as well. It sounds like a silly thing to suggest, but we had to make sure that we could ensure the supply of that GX Media Suite on site at both Gold Coast and Brisbane, because what we didn't want to do is we didn't want to transition over to the GX Media Suite and then have to switch backwards and forwards. So we worked very closely with our suppliers to make sure that we had a good and steady supply of that media. We implemented the GTL, so the single-step medium without the antioxidants, at our Gold Coast clinic in September 2022. And we reviewed, that data was reviewed by our group scientific advisory committee, so our nationwide, scientific directors, in January last year. And based on that review, we then implemented GTL in Brisbane for our Brisbane patients in February last year. And then we've implemented the GX Media Suite. So that's the single-step medium suite containing antioxidants. We implemented that in the Gold Coast in April last year, and then more recently in Brisbane in September last year. And obviously, an important part of any implementation plan is to review the KPIs. So it's to set expectations and then review those KPIs to make sure that it's having the desired impact on our pregnancies, both our embryo development, but ultimately our pregnancy outcomes as well. This is just an example of some very simple patient frequently asked questions. More than anything, just to provide reassurance to patients, that this is not going to have a negative impact on their chances of success, and in fact, it's likely to increase their chances, but also reduce the risk associated with having their embryos in the laboratory. And we provide all of this to our patients at no additional charge. Other clinics might make different decisions, but at Monash, we always feel like that patients deserve to have access to the best treatment available. And so that's why we made the decision to provide this to our patients at no additional cost. During the transition period, obviously, there was going to be 2 different culture media suites in use in the lab, and we wanted to make sure that patients that started in sequential media, started that cycle, make sure they finished that embryo culture in this sequential media suite, and similarly for the single step medium. So it was obviously important to have a very clear plan. And this is just an example of a very simple email detailing the transition plan from sequential to GTL. So the yellow highlighting is the phasing out of the sequential G1 plus G2 plus media suite. and the green was the phasing in of the GTL medium. And again, something as simple as this really helped that transition to go very smoothly without a hitch, both on the Gold Coast and in Brisbane as well. And so we replicated this plan multiple times, obviously Gold Coast and Brisbane, and then also when we were going from GTL to GXTL in our Gold Coast and Brisbane clinics. So it doesn't have to be complicated. I think that's the take-home message from that. So we're currently using the GX Media Suite in our laboratories in Brisbane and the Gold Coast. So we use GX IVF for egg collections, conventional IVF inseminations, denuding, and sperm preparation. And we use the GXTL basically everywhere that we used to use the G1 plus and G2 plus. So for ICSI, for embryo culture post-denuding, FERT check for IVF insems, embryo biopsy. We use GMOPS for making vitrification and warming solutions. So it's the only component that we haven't switched over to the GX series yet. So we're still using the GMOPS, but we're certainly looking at implementing the GX series for GMOPS as well. One of the things that I wanted to kind of highlight here is that for patients having PGT, historically, and just very similar in a lot of clinics around the world, certainly using sequential media. Most clinics will do their assisted hatching on day 3. So they'll do their laser assisted hatching and then move the embryos over into the G2 plus medium, or the blastocyst culture medium. So I guess with the implementation of single-step media, obviously we don't need to take embryos out on day 3 anymore. So it made us stop and rethink, well, when are we going to do that assisted hatching? It doesn't make sense for us to take the embryos out on day 3 anymore. And we landed on, and this was based on experience from my previous clinic where I worked for quite a long time. And the logic of doing a laser-assisted hatching on day 4, in the afternoon of day 4, is it maximizes the length of time of uninterrupted culture. So it means we're culturing them as long as we possibly can. Some clinics will do hatching and biopsy at the same time on day 5. But I think for us, what we've found is that when we do the laser-assisted hatching on day 4, we're doing it on embryos that are, expanded, and so the embryo is right up against the zona. And to make sure that we breach that zona, often then you're nicking the embryo, and that causes the embryo to collapse. This doesn't happen with mouse embryos. For those who've worked with mouse embryos, generally doesn't happen, but with human embryos, they will collapse. And so we just found that on day 5, those embryos were sometimes taking quite a long time to re-expand. And we ended up having to biopsy them on day 6. Rather than day 5, when if we had hatched them on day 4, they would have been hatching on day 5, and we can get them out of culture that 24 hours earlier, which I think is quite important, and is, I guess, a good marker of a high-quality IVF or high-quality embryo culture system, is we're getting as many embryos as we possibly can out of the system on day 5 as opposed to day 6. And like I said before, we don't do, so that's the logic of doing the day 4 assisted hatching, but I certainly appreciate that we're differing views on that one. But that's kind of where we've landed with that one on day 4, the afternoon of day 4. And we actually don't do the refresh anymore. That was, I guess, a bit of a safety blanket for us. We did refresh that media on day 4 for a little while, but we've stopped doing that in both of our clinics now. So what have we seen so far in terms of results? So the blue bars there are the sequential media suite, so G1 plus, G2 plus, and that includes around about 6 months of data immediately prior to the GTL implementation. So this is the Gold Coast and Brisbane clinics combined. The orange bars are the single-step media without antioxidants, so the GTL, and we used that for about 6 months before making the switch to GXTL. And then the grey bars are the results from the GXTL, so the single-step medium with the antioxidants. So you can see that, and I always put the average age there just to show that these outcomes are not being influenced by different average age or different average ages in those groups. We've seen a slight increase in fertilization going from sequential to single-step to the GX series. We've seen quite a good increase in the utilization. So it means that we're actually, freezing more, we're creating more good quality embryos and freezing more good quality embryos than we ever have before. And on that point, it's actually really important to take that into account. If you start to see these increases in utilization and pregnancy rates from your culture systems, that is going to have a knock-on effect to your freezing and your cryo storage facilities. You'll be having patients who are going to get pregnant more quickly, and they're going to be storing more embryos for longer. It will vary based on regulatory environment, but it means that you do need to, it will have implications for your cryo storage facility, and you'll need to consider how you manage that increased volume of embryos being stored. And again, there are lots of implications for that, just physical space, but also insurance as well. So getting back to these results, we've seen an increase in both fertilization and utilization. And in the GX media suite, which is really promising to see. And it's hoped that over time, this will lead to an increase in our cumulative pregnancy rate per stimulated cycle. The clinical pregnancy rate increased from going from sequential media to single-step media. And we've seen it pretty steady from the GTL to the GXTL. And this is all from our fresh embryo transfers. But in both Gold Coast and Brisbane now, generally, most of our patients won't have a fresh embryo transfer. Most of them will have embryos frozen, and they come back for a subsequent frozen embryo transfer, a month or two down the track. So that's our fresh embryo transfer data from our frozen embryo transfer cycles. So again, same color coding. So blue is sequential, orange is single step media, and gray is the single step media with antioxidants. And we've seen a slight increase in survival, which is good. So it's increased by a couple of %. But the one thing that we've really seen an improvement in is the clinical pregnancy rate. And that's, starting to nudge towards 50%, about 47, 48%. And it's still early days. And so, sorry, these are embryos that have been cultured in the GXTL media suite, and frozen, then subsequently thawed and transferred. So it is still relatively early days, and so as we collect more of this data, we'll certainly start to, untangle the impact that PGT has on these outcomes, because that will have an influence. But we've certainly seen a positive increase in the clinical pregnancy rates. Which, like I said, certainly we hope that trend will continue, but it's certainly a positive sign so far. So on that note, watch this space. We'll certainly continue to present this data as we collect it. It is very early days, so we'll be monitoring the results with a very keen interest to see how the culture systems continue to perform over the longer term, both in terms of quality outcomes, but also risk reduction. And that is a really important part, which I haven't really talked too much about today. But if we're improving our outcomes and we're also reducing the risk associated with our culture systems, that's certainly a really positive outcome. We've certainly provided assistance and protocols to our other Monash IVF laboratories, making that transition to single-step media. And we're always happy for discussion regarding our experience with the media suite. So please feel free to reach out to me. I'm always happy to have a chat. But as I said earlier, I am really incredibly grateful for the scientific teams that we have here in Queensland who have executed these changes so incredibly well. And I cannot overemphasize the importance of really clear communication and getting staff engaged, because it will ultimately determine the success or otherwise of how well these changes are implemented in your laboratories. And the work from my teams have certainly contributed to the positive changes that we're seeing so far. And ultimately, it's our patients that win out of that. Thank you very much.
Hello, thank you very much, Dr. Daniel Morgan. Now, if you just wait for a while, we'll see the open now for the questions. How do I get to the questions here?
Hi, Doctor. There is a question here.
Okay, all right.
Can you read the Q&A box there?
Yeah, do you want me to read it out?
Yes.
Yeah.
Yeah, so there's a question. Based on your experience of hatching blastocysts on day 4 for biopsy on day 5, were there many blastocysts that had the ICM part hatched out instead? If yes, how would you biopsy these blastocysts? Yeah, look, that is the trade-off. And so sometimes you will have embryos that will have that inner cell mass hatching out. Look, we haven't collected data on it to give it an indication of what percentage of embryos. If it's the whole ICM kind of hatching out and it doesn't allow safe access to the trophectoderm cells, then it does mean that sometimes we culture those embryos to day 6 to allow the embryo to hatch out further. Quite often those embryos are fully hatched on day 6. But sometimes, you know, you might be able to manipulate, I guess, the trophectoderm to access some of those trophectoderm cells without going too close to the inner cell mass. It's one of those things that you just got to take on an embryo by embryo basis. But it is one of the trade-offs, or one of the downsides of doing that hatching on day 4. Sometimes in the afternoon of day 4, and we're certainly seeing more of this, is that if the embryos are starting to show the early signs of an inner cell mass, if they're an early blastocyst or even a blastocyst in the afternoon of day 4, and you can see the inner cell mass or some cells that are starting to group that might go on to form the inner cell mass, we train our staff to hatch on the opposite side of the embryo to minimize the likelihood that the inner cell mass is hatching the following day.
Thank you, Doctor.
That's okay. Yep.
Yeah, there is another question for you.
Yeah.
Shall I read it for you?
Yeah, I can read it. Yep. So
How do you read it? Yes. Carry on.
Yep. So the next question is, do you routinely implement antioxidant infused culture media for all patients, or is there a criteria that you follow in any sense that you may think that antioxidant may not be beneficial to them? No. So it is offered and done routinely for all patients. There are some patients that might access, I guess, alternative media suites specific to, I guess, to their prescription from their clinician. But as a general rule of thumb, we use the antioxidant media for all patients.
Thank you. While we wait for the third question, yes, you have the third question here.
Yeah. Do you find that blastocysts formed much earlier in GXTL compared to others that are cultured in other media? We haven't, I guess, collated data, you know, specific data on that. Anecdotally, the staff are finding that we are freezing and biopsying more embryos on day 5 than we used to previously. So it does seem like there is a bit of a shift towards earlier blastocyst formation and getting the embryos out of culture that little bit earlier, especially for PGT patients. So which is great. I mean, from my perspective, one of my central dogmas is always trying to get embryos out of culture as early as we possibly can, because we know that the longer the embryos are in culture, they do start to accumulate epigenetic changes as well in the genome that we really don't know nor understand the impact of those changes. So as a general rule of thumb, I like to get embryos out of culture as early as we can.
There seems to be no new questions. Maybe while waiting for the questions, I could ask you something.
Mm-hmm.
Would you think there is a potential for improving oocyte quality through antioxidant interventions before or during the IVF cycle?
It's probably more a clinician question, I guess.
Yes.
And it's probably, I guess, collating that information as well is going to take a bit of I guess quite a bit of collaboration between clinicians and the laboratory. You know, sometimes we don't always have access to, I guess, the interventions that patients have
Right.
I guess have gone through from a clinical perspective to then correlate the impact of that on oocyte quality. Look, it has the potential, I guess, and I don't think there's evidence out there that contradicts that idea. But whether or not there's actually supporting evidence, I don't know that there's a lot out there at the moment. And also, how do you define oocyte quality is probably quite a question that we could talk about for hours. At the end of the day, for me, a good quality oocyte and a good quality sperm makes an embryo that goes on to make a baby, but that's somewhat simplistic.
Would you have any objective methods of assessing oxidative stress in oocytes?
Probably
Do you see
about
any morphological changes? Or?
Yeah, it's probably a bit outside of my field of expertise. So yeah, I'd probably have to defer that one to people who have probably got a bit more experience with oocyte, oocyte morphology and quality.
I think we have another question for you, Dr. Daniel.
Yeah, so do you notice any difference using GTL and GXTL, especially on the blastocyst stages, with having more hatching blastocysts on day 5? Yeah, look, again, it's one of those ones that's probably a little bit difficult to objectively assess because so many of our patients will cycle on with the intent to do PGT, and so we assist that hatching process. So do we find that we're getting more hatching blastocysts on day 5? Well, yes, we are, but it's because we're assisting that process. So and it kind of goes back to what I was saying before, that we are finding that we are utilizing more embryos on day 5 compared to previously, which probably, you could probably then extend that argument to say that if we weren't doing that assisted hatching, perhaps we would be seeing more hatched blastocysts on day 5 compared to day 6. But it's probably hard for us to assess because of the amount of PGT that we do in our clinics.
Yes. Do you foresee any ethical considerations related to the use of antioxidants before or during the cycle, or even other supplements?
Oh, look, I think, again,
has that been discussed? Is that been an issue? Has that been under scrutiny or?
Yeah, look, I think certainly from a clinical perspective, and again, it's probably a bit outside of my field of expertise because I'm not a clinician, but there certainly are some clinicians that will, I guess, put their patients on some antioxidant supplements. I know that sometimes they can be quite expensive, and when the impact or I guess the positive impact of those supplements is unknown, then you could make a question, or you could make an argument for, is that ethically the right thing to do? But as I think, as long as we're holding to the Hippocratic Oath of doing no harm, as long as we know that we're not doing anything harmful to the patients, then sometimes, as long as patients are aware of the risks, and I think that's where informed consent is really important. But as long as we're informing patients of the risk, then I don't think there's a huge ethical concern there.
Right. We'll wait for some questions, some more, Doctor. Meanwhile, can I just ask you, does the oxidative stress affect different stages of the embryo development, like fertilization, cleavage? Are there any specific steps that which you find vulnerable to oxidative stress?
Yeah, it's a good question. I probably don't know the full answer to that on my own, to be honest. And probably some more reading that I need to do. We know that certainly the earlier, like cleavage stage embryos, are more susceptible to changes in culture systems, or to, I guess, interruptions to culture systems, whether that's to refresh media, change media, whatever it is. We know that the earlier stage embryos are more susceptible to changes, and so I think in those very early hours and days of embryo development, creating an uninterrupted and stable culture environment, I think is quite important. So anything that we can do to minimize our interactions with the embryos is certainly going to help that, for sure.
Thank you. Thank you, Dr. Daniel. I think there are no further questions. So MSART and EP Plus takes this opportunity. Thank you very much. I know it's your holiday. You take time
That's
off.
okay.
Take time off, and it must be late in the evening for you. Right?
That's okay.
Thank you very much, Doctor.
Right. Thank you. You're very welcome. Thank you for having me.
Sure. Welcome. Okay, ladies and gentlemen, our next talk are we okay? Yeah. Our next talk is an optimization of oocyte collection with a focus on safety and efficacy. Now, as we know, IVF practice in Malaysia has facing increasing scrutiny in terms of ethical implications, potential risks, and the regulatory landscape. These concerns are understandable as we are dealing with some sensitive issues, and we as clinicians have the responsibility of prioritizing patient safety above all else. Our guiding principle must be first, do no harm, and safe oocyte collection lies at the very heart of our practice. So to hear us out today, we have the privilege of listening to a very distinguished, well-respected, admired, maybe I can say a blue-eyed boy of TMC and MSART, Dr. Navdeep Singh Pannu, who will take us through the intricate world of oocyte collection. He's an consultant obstetrician, gynecologist, and fertility specialist of TMC Fertility Center, and he's also currently the president of MSART. Dr. Navdeep.
Thank you very much, Nato, for a kind introduction. Well, today I will be talking to you about this topic, and let me share my slides first. Okay, so I'll be talking about optimization of oocyte. Let me bring this down first. Okay, optimization of oocyte collection. There'll be 2 points to this: one, safety and efficacy. Somehow it doesn't seem to change. Changing. All right. Okay, so the outline of my talk today, I'll talk briefly about oocyte retrieval, and I'll be discussing about the sense needle. I'll be presenting some studies, and I'll give you some experience that I have since I've started using this sense needle. So, just like all surgical procedures, we first have to take a history of the patient, find out the potential risk, and then we have to educate them and counsel them, inform them about the procedures, the benefits, and eventually take the consent. Here we have to look for, and the initial stages, when you take the history, make sure no risk of like bleeding tendencies, like thrombocytopenias, or certain issues that they had if they had their IVF cycle in another center or previously. So then we'll start off with the ovarian stimulation. Now, in doing ovarian stimulation, we will decide on the most adequate dose for the patient, and that's determined by the patient's like age, the BMI, the antral follicle counts, the AMH. And if you have the benefit of a previous cycle, then you can determine the best amount of dosage of medication to be given to her. And here we have to keep in mind that we would like to avoid ovarian hyperstimulation syndrome. And subsequently, we'll do ultrasound scans maybe 2 or 3 times during the IVF cycle, and we have to monitor the growth of the eggs. And the other thing about ultrasounds during the ultrasound scan is you will know where the ovaries are located. Sometimes some ovaries may be a little bit higher than a little bit higher up due to previous surgeries where they have additions. So you have to keep in mind all these things. And subsequently, the trigger shot. The trigger shot would be, in my practice, if I have more than 15 follicles, then I generally give the agonist trigger shot. And however, if we have lesser than 10, then I will give them the HCG shot. So basically, I would like to avoid ovarian hyperstimulation syndrome at all costs. And if you are worried, you want to give her the HCG, then you might as well give her some form of cabergoline a few hours prior to the trigger shot to reduce the risk of ovarian hyperstimulation. And subsequently, the oocyte retrieval, where we'll be going more deeply into it now. When we talk about safety, the first thing will be quality control. You must have strict protocols where your staff, everyone have to follow the same thing. Aseptic techniques, very, very important. All your instruments and all have to be cleaned and sterilized. And as for prior to the oocyte retrieval, you want to wash the vagina, we avoid any form of antiseptics like povidone or spirits. We do not use that because that can be detrimental to the eggs. So I generally use normal saline to wash. And then after which, then you have staff training and to look for complications. Now, what complications you want to look out for? One is bleeding, infections, all these things you have to look out for. So, and when you do the oocyte retrieval, every time you must ensure that you visualize the needles at all times, because you do not want to injure the blood vessels. You do not want to injure the bowel, especially when patients had previous surgeries where the oocytes are, where their ovaries are high up, and then you tend to go a little bit deeper than usual. So please ensure that you see your needles at all times. Now, as for anesthetic, I generally allow my anesthetists to choose the type of anesthetic that they are comfortable with. Generally, we use a laryngeal mask, or some of them even use the IV anesthetic agents. And the main purpose of having an anesthetist over there is at least you have another doctor. So in case there's a complication, another doctor is there to help you out. And I just feel the anesthetist should be the main persons who will sedate the patient. So at least then, as for a clinician, for us, fertility doctors, we can concentrate on the egg retrieval process. But of course, some doctors also give conscious sedation, like some the other things would be like oral medication, paracetamol prior to the procedure. And some of them even give paracervical blocks to the patient. There are certain centers where, especially in, like, for example, in Japan, where they do minimal stimulation. They may have only one egg follicle. They do not give anesthetics at all. So, and the other thing will be continuous monitoring of the patients. As I mentioned, is still a surgical procedure. So we should monitor the patient vital signs at all times until she is discharged. So our main aim is to collect as many follicles as possible and as safely and as fast as possible. So generally about 15 follicles will be just nice most of the time. And we want to avoid damage to the egg follicles. And next will be the laboratory techniques, which the embryologist will be in charge of. Now, let's talk about pain. So prior to the procedure, we have to ensure the patient's mindset. They do not feel that, read them in Google, it's very painful procedure, this may happen, that may happen. So just have to calm them down and look, and tell them that this procedure is painful. Hence, we are giving some form of analgesia, anesthetic, and painkillers subsequently. But I generally assure them they can still go on with their usual, house work and all. I mean, at lesser degree. And I always ensure at least the partner is always there with them when they're about to discharge. So at least then they have some support. During the procedure, you have to be very sure about not puncturing the vagina many, many times. So generally start with one end and complete the other. And do not punctuate too many times, because that will cause more bleeding and more pain. And always know the anatomy of the pelvis, especially the patients who had previous surgery or those who have fibroids where they have displaced the ovary slightly, and try to minimize the duration of the procedure. Be careful on patients who have thrombocytopenia and difficult cases, for example, those with lots of eggs and those previous issue of endometriosis with adhesions and all. So this procedure, this oocyte retrieval, has been around for many, many years. So, but it's it's an ever-evolving thing. So they have lots of new technology right now where they help us to do this procedure with more clarity and with better type of ultrasound scans, which are higher resolution. The other thing will be to reduce pain and bleeding. They have come up with newer needles, thinner needles, where enhance the precision, reduce trauma. So basically, reduce pain, reduce bleeding, reduce any form of hemorrhage, and they are still very, very sturdy and stiff. So this is basically the sense needle. We have a unique design, 17 to 20 gauge. The last part of the needle is the one which is very, very thin. So I generally use this nowadays most of the time in all my cases. So one moment. Okay. The main benefits here is basically you have a thin needle and it does not reduce the overall time of the does not cause any problems with the oocytes, and not much of increase in time or any an extra time for you to do the procedure. If you can see, the sense needle and the conventional needle is 59% lesser in size. And nowadays they have the double lumen. For all those who like double lumen, you can use this too, which has 56% less in the size. So the part which has lesser size is the last 50 mm of the needle. So the initial part can go in, and this part can help stabilize the needle. Why is my needle not working? Okay, so let's talk about some studies where we want to look at pain and bleeding. These are the two main things that we clinicians are very worried about during a egg retrieval cycle. So this study talks about the effect of oocyte. So it talks about the size of the needle, the diameter during the retrieval. So this study was done in the Netherlands, where they had 47 people who had the reduced needle and 48 had the standard type of needle. So overall, the ages were similar, the body mass index was nearly similar, and the amount of follicles retrieved was nearly similar. And the oocyte retrieval too was similar. So the duration for egg retrieval, not much. There was not much of change. One's 8 minutes, other one's 7 minutes. And ongoing pregnancy rates were similar. So when you talk about pain, so they used the visual analog scale scoring for these patients, and they found that those patients with reduced needle had the mean score was much lower, and even you see the severe ones. So, but those had severe pain was much lesser than the ones which had a lot of pain. So here you can see that the pain was much lesser. So you can see even this, how many of these patients required more medication? None. Okay, at least once were 3 and none who required additional dose. Okay, and then look at the bleeding. The bleeding too, the rate of blood loss was less. So basically, the clinicians looked at what was less, normal, or even more. So the numbers were low. See, because the needles are very, very thin, hence the tissue damage is much lesser. So this is another chart. You can see those with the reduced needle had much lesser pain compared to those with standard needles. Now, another study that was done in Sweden too, where they had about 250 plus patients, where they wanted them to sense needle and the normal conventional needle. And here again, they used the visual analog score. And they looked even at pain during the procedure, and after the procedure, additional analgesia if required, the time spent for the aspiration, vaginal bleeding, and number of oocytes retrieved, and fertilization, and eventually clinical pregnancy rates. So what they found was there was 19% less pain when using the sense needle, and 8% patients were given additional analgesia when they used the conventional needle. When you ask the clinicians to gauge about the bleeding, most of the bleeding occurred in the conventional side, and there was much lesser bleeding in the sense needle side. So as for aspiration time, there was no difference. The oocyte recovery and fertilization, there was no difference. So as for the oocyte safety, similar. So another study here where we spoke, where they talk about the when we talk about the use of this needle. Okay, so initial study in 2009, the 51 patients where they looked at pain experienced by the patient in relation to the size of the needle. And the follow-up study in 2012 for 100 people, they checked, they assessed the consumption of the fentanyl. So in this study, they found that the pain score was much lesser in the patient, the sense needle group compared to those who had used the normal needle. So here, the patients were assessed by themselves. The nurses asked the patient to determine their pain score, and the doctors too had to determine the patient's pain score. So you can see both the doctor and the patients had visually much lesser pain. Why is not moving? Okay, so and the other thing was like the patient in the sense needle had reduced consumption of fentanyl compared to the other other needle, conventional needle. So in this one study, this was done in Japan. So the Japanese nowadays prefer to use mild stimulation or even no stimulation. Some of them even give oral medication for ovarian stimulation. So they end up having 1 or maybe 2 eggs. So what they believe is that they prefer not to give any form of anesthesia to the patients. So these can be done. They may give some paracetamol, but that's about it. And they did not use anesthesia in this particular study. So there no anesthesia treatment was given, and there were 75 patients. So they had only aspirated 1 follicle. So what they found was, well, similar like what we saw in the previous studies, that these patients were similar groups, and they had the similar fertilization rate, and they also had the pregnancy rates were not significantly different. And they found that the study did not show any difference in terms of fertilization or pregnancy rates with the thin needle. And initially, we all felt that a thin needle may damage the oocytes, but this study and lots of other studies so far did not show that. So hence, they found that there was less pain and less bleeding. As you can see the chart over here, they used the visual analog scale pain score, and they found that the sense needle had a much lesser amount of pain. So basically, as you can see, the overall pain score was lesser. There was less amount of bleeding, did not increase the oocyte collection time, and did not reduce or did not damage the oocytes. So I've been using now the sense needle for many years now, and basically I just use that in my practice. I hardly use the normal conventional needles anymore. I don't use double lumen. For me, whether 1 egg or 2 eggs, I still use the single lumen sense needle because I find it. I have the similar experience where less pain, less bleeding, and it's very, very easy to use. One thing that only one problem that we have is if the oocytes are placed very high up in the pelvis and it's adhered very closely to the uterus, then when you have to go through the myometrium to do egg collection, then the tip of the needle tends to bend a little bit. But after a while, then you just have to observe the echogenic marking, and then you'll know where the needle is going. But in certain cases, then you may want to use the conventional needle if you're unhappy with the deviation of the needle. So basically, in this needle, you can still see the echogenic marking is imprinted on the top part of the needle, and and it's definitely something which is easy to see on ultrasound scan. You can use the square method or even the weighting method. And generally we use the square method, but start from one end first and then slowly work yourself till the end. And that way you don't have to puncture the vagina many times, and hence you will avoid any form of bleeding. And if in case you are bleeding, then put a bit of pressure for about 30 seconds to a minute, and most of the time the bleeding will stop. And if the bleeding still persists, then usually I tend to use things like ferric subsulfate, also known as Moncel, similar thing that we use for colposcopy. If in case there's some additional bleeding, I tend to use that very rarely. And of course, the bleeding still persists, then you might want to stitch. So always have a long needle with you, needle holder with you. So yeah, so that's the next part. So the other thing about egg retrieval is, what is the ideal pump pressure? So there are a lot of factors which determine the quality of the egg. Is your pump pressure, your needle type, needle length, your tubing pressure. All these things will determine the final outcome. So if you want to check whether the pressure is right, so just try to calibrate your machine to make sure it aspirates about 10 ml of water between 10 to 25 seconds. To achieve that, the ideal pressure will be between 10 for the single lumen, 10 to 100 to 120 millimeters of mercury. I generally use about 120 millimeters mercury. However, if you are a double lumen believer, then you might want to increase the pressure to 150 to 170. And so some doctors prefer to flush with a double lumen. I generally don't do it. I have not done it for many years already. So, but those who like to flush, then they do it because the patient has very less eggs, and they want to ensure that they retrieve those eggs. So hence, some of our colleagues do flush, but a lot of studies have shown that it does not improve the number of oocytes retrieved, but it increases the procedure time significantly, and also the bleeding that comes along with it, because the needles are slightly thicker. So as I mentioned, that they do it for patients with poor responders or to have low follicle counts. So even in the SENS double lumen, they still have the benefits of the normal needle, but it's a thinner needle. Hence, you have lesser pain and lesser bleeding. So as I mentioned earlier, 56% less in size. So in short, in summary, for you to get good quality eggs, you need to be fast, precise, and retrieve as maximum number as possible undamaged oocytes without any complications. So end of the day, as I mentioned here, I generally use a SENS needle, and then over the years I have no issue with it, and the time of retrieval did not change, and pregnancy rates still maintain whether you use the conventional or not. But the pain and bleeding definitely is reduced. Okay, thank you. Any questions for me?
Right. Thank you, Dr. Navdeep. We'll wait for the questions.
Sure.
Okay, maybe I can start you off, Navdeep, while we wait for the questions. With the time constraints, when you talk to the patient and take the consent and all that, are there any aspects of the procedure that you would emphasize more to the patient? What is your normal consent taking before oocyte retrieval? What are the things that you would suggest that clinicians should highlight to the patient? You can't go through a whole lot of things, isn't it, when you take the consent?
Yes, so basically the consent form, the consent is generally taken the time when we start the patient on the IVF procedure, where by starting the injections. We'll tell them, look, the procedure involves taking anesthetic agents. You may have a bit of nausea, vomiting. You may have a bit of drowsiness after the procedure, and you have to, go back home and sleep on that day, and ensure that you have some support. That means you have another family member or your partner should be around the clinic to take you home. Do not drive. And the other things would be like risk of infection, bleeding, injury to the bowel vessels. All that we'll have to explain it to them. And even allergic reaction to certain medication. And of course risk of ovarian hyperstimulation syndrome. And also mention to them that there is a small risk of that occurring. If it's severe, then you may need to be admitted in hospital. Additional painkillers or certain other additional treatments will have to be taken. Yeah, that's about it. And also explain to them that I'll be giving them antibiotics and some painkillers after the procedure. But to be honest, that most of the patients they will take a day of painkillers, and the rest of it they will not take it because they don't feel any pain. But the patients who have a lot of pain are the ones which generally have more than 15 or 20 egg follicles. Then they have more pain. Otherwise, those who have less than 10, they are quite comfortable.
Thank you. Just about coming to the flushing of the follicles. So what would you do when you see a good looking follicle and then you aspirate it and there's no oocyte there? Aren't you tempted to go for it a second time after flushing?
Well, of course, yes. We will be tempted to do so. We can do it until twice at least, once or twice, and if still you don't get any egg, then it's just too bad. Then probably the other reasons why she had only one follicle, probably the quality of the egg was not good. Hence you didn't get the egg follicle. Probably the second time around you want to delay the egg retrieval. Probably if you tend to do it at 35 hours, you might want to delay it to 36, even 37 hours the next cycle. As for your trigger injection, you might want to give a dual trigger with HCG and also with the agonist at the same time.
I think we have a question for you, Navdeep. Would you like to see it?
Can I just have a look at it? Do you? Oh no, I think that was. Yeah. Sometimes when we need to go through myometrium and the needle gets obstructed and cause difficulty to aspirate the follicles. Any tips to avoid this? Well, what you can do in those kind of scenario is that get a nurse to get your assistant to flush the needle a little bit with some culture media, and then try again. Because sometimes yes, it can get blocked. So we just have to try to aspirate it and inject some culture media, and hopefully the tissue which is obstructing it will get dislodged. That's the only thing you can do.
Thanks. There's another question also, I think. You want to see that?
Come on, not see. Oh yeah, I can see. Thank you for a great talk, Navdeep. Do you collect from the smaller follicles during OPU? Not really. Anything which is less than 13 mm, then I tend to just leave it alone. So anything which is 14, 15, 16, of course you get egg follicle. But so far, like very small egg follicles, 12, 10 mm, well, I don't think it's going to benefit us at all. So no, I don't retrieve smaller egg follicles.
Dr. Navdeep, so currently, are you able to run a practice without even a moderate OHSS now that you have your antagonist cycles, your agonist trigger? I mean, just for discussion's sake, I think severe OHSS now is more or less not seen at all. But moderate, the patient come back the next day with bloating and signs of mild ascites. Are you able to overcome that now?
Yes. the last time I had a patient with severe OHSS was probably about 8 years ago, 2000 no, more than 10 years ago, 2012, 2013. So a long time ago where I got a patient who's been admitted for ovarian hyperstimulation syndrome. And generally, so I don't see severe ones anymore. I only see some moderate ones. Yes, they have a bit of bloating, a bit of pain, a bit of cramps. So that too very rarely. So because what I do is if I have more than 50 egg follicles, and I tend to give them the agonist trigger, and I also routinely give them some analgesia, some NSAIDs, Ponstan, or even Celebrex. Tell them to take it for 5 days and give them a good MC, let them rest at home, and I see them after about 5 days later. Generally, they'll just complain that the first few days it was a bit of pain, and that's about it. So very rarely have patients coming back to my clinic with complaints of pain.
There's another question for you, Navdeep. Can you see that?
Yes, okay. In case of endometriosis, at times both ovaries situated behind the uterus and indeed, how do you approach OPO in these cases? Okay, firstly, if you can see the egg follicles clearly, you can go through the myometrium. You can go to the uterus to collect those eggs because you're very worried about blood vessels or even the bowel around it. So that's what I do. I just go through the uterus. Secondly, in certain patients where the oocyte, the ovaries are a little bit on the higher side, I'll get my nurse to put some pressure over the abdomen and try to push the ovary down. And from below, we have to press our probe a bit with more strength, a little bit to collect the eggs. And sometimes we have to move the bed a little bit, like tilt it a little bit to access the eggs. So yeah, so that's what I generally do. But I've many times I've gone through the myometrium, and generally there's no problem. It's okay. They don't have extra pain. There's a bit more bleeding because you tend to go through tend to hit the cervix a little bit. But as I mentioned, just put a bit of pressure for about a minute or so, and the bleeding still persists. Give them put a bit of Moncel, ferric subsulfate, and the bleeding will tend to stop. Sometimes you're still worried, you can give them tranexamic acid, and during the procedure, we see a lot of bleeding, and that will be sufficient.
The other thing you could also do, Navdeep, is to apply pressure with the probe on the vagina while your assistant is applying the under pressure before you push the needle through.
Yes, so you can stabilize the ovary.
Yes, stabilize the ovary. And then if you're worried about bleeding, then you can also do a Doppler to see the vessels. That's one thing that you can.
Yes, I totally agree. Especially if you have a ovary which is situated a little bit on the higher side, you'll be worried if there is a blood vessel around the area. You can on your Doppler to assess and see whether or not is there a blood vessel there or not, and then try to navigate away from the blood vessel.
Yeah. And the other thing, the one you mentioned about the pressure, I think 150 to 170 is a bit on the high side.
That's for a double lumen.
Even for double lumen.
But that's what the company advice recommends. But of course you can.
I've never exceeded 120. I think 120 is usually less stress on the oocyte.
Right. So basically, I don't use double lumen. So I am fully a single lumen person. So my pressure is generally about 120.
I think we have another question.
In case of a larger follicle, 122, is there any role increasing the pressure more than recommended pressure? Nope, there's no role at all. You will run a risk of damaging the ovary, the oocyte, if you increase your pressure tremendously. So I don't recommend it, and I don't do it either.
Okay. So, all right. So I think we come to the end of the hour. First of all, I would like to thank all the participants. I think we have a good number of participants, about 162. Then I'd like to thank our industry sponsor, EP Plus, also MSART Secretariat, Radha and Amira, who have done a good job putting all this together. And last but not least, our two very eminent speakers, Dr. Daniel Morgan and Dr. Navdeep Singh Pannu. So with this, we conclude today's session, and thank you again. Bye.
Thank you very much and good night. Bye-bye.